I am Ozlem Goker-Alpan. I am the medical director and founder for Lysosomal and Rare Disorders Research and Treatment Center located in Fairfax, Virginia. Today I would like to present the research highlights on Fabry disease from the WORLDSymposium 2020 that occurred in Orlando, Florida. Fabry disease, actually, is fair to say, I think now, is the most common lysosomal disorders. And it's one of the two disorders with an X-linked inheritance. The culprit for Fabry disease is the mutation in a gene that is called the GLA gene that results in the deficiency of the lysosomal enzyme alpha-galactosidase A. This enzyme is responsible in the lysosomal membrane to break down of a complex lipid. It's called GB3 or globotriosylceramide. What happens when there is the deficiency of this enzyme? There is progressive buildup of this complex lipid within the cell first, causing a cellular dysfunction, but then which spills into the tissues, then the organs, and then causing end organ damage. And the major three organs that are affected is the heart, kidneys, and the central nervous system. However, the other complications of Fabry disease also come from when the peripheral nervous system is affected. So pain is the major symptom in presentation of Fabry disease. The standard of care is enzyme replacement therapy. You can replace the deficient enzyme. It is prescribed every other week, and it is given through an infusion, which may take from anywhere from 2 hours to longer if the patient has issues with it. There is a recently approved oral medication, migalastat, which acts a different way than enzyme replacement. It makes the protein more functional, and that in the cell that the functional protein may churn down this unwanted lipid. This is not enzyme replacement therapy. This is a smaller molecule. It can go to different tissues, which may be a problem in enzyme replacement therapy. But we are living in very exciting times because there are numerous treatments are being developed. This includes small molecules that may reduce this abnormal lipid deposition by interfering with the lipid synthesis pathways, glycotriosylceramide. And also there are a few gene therapy trials are coming into the phase 2 and phase 3, where we are actually starting to enroll patients. So WORLDSymposium, this is the 16th year that this event is taking place, and I started attending WORLDSymposium the second meeting. I was told the first meeting was about 32 people or so. The second meeting I attended was about 110. There are now more than thousands of people are attending, and this meeting is focusing on the lysosomal storage disorder that includes these group of disorders that Fabry disease belongs to. It's fair to say there were more than or around 100 presentations dedicated just for Fabry disease. There were about 74 posters and about 18 talks about Fabry disease. So Fabry disease was one of the highlights of the symposium this year. So the last 2 days, they were probably the most exciting days for a clinician because we learned about a lot for the effect of the existing therapies, but also we got informed about some basic science that would lead to development of therapies, also some clinical trials that could be used in near future for treating patients with Fabry disease. So let's start with the enzyme replacement therapy, and agalsidase beta is the FDA approved enzyme replacement therapy, as known that it is given every 2 weeks, generally I would say, and the dose is 1 milligram per kilo of the patient weight. And there is extensive data that is presented in this meeting that actually keeping up the treatment and continuing treatment that stabilizes multiple end organ that is impacted by Fabry disease, that it improves the cardiac outcomes, progression of renal decline, and reduces gastrointestinal problems in patient Fabry disease. These studies were presented by multiple researchers and clinicians that includes the Cincinnati group, Dr. Hopkin and Dr. Henderson. And now there is this oral chaperone therapy for Fabry disease. So migalastat is the second chaperone that is approved by the FDA for genetic disorders. And it's been in the market for over close to 2 years now, and then we are getting some real life experience. There is not a whole deal of data that still exists except for the clinical trials, but UK group presented several posters on Fabry disease and migalastat. They observed migalastat was effective in both treating patients who have never been treated or naive, or previously taking enzyme replacement therapy. We call them switch patients. And mean kidney function that is measured by eGFR, estimated glomerular filtration rate, a range between 81 to 79, so this is not a major difference, so probably it's the standard error of the study, so which means that the kidney function remains stable. And then the Fabry disease glycosphingolipid marker, lysogb3, also remains stable with a very mild decrease from 7.2 to 7. And among all these 78 patients, 3 patients elected to switch back to enzyme replacement therapy due to exacerbation of their gastrointestinal symptom, and patient, one of them actually perceived there was deterioration of the cardiac function. So this is a different kind of treatment. You need to have a small molecule that is stabilized in the bloodstream, then the tissues and organs to a certain level to do its function. And it's the oral chaperone. So basically it binds to the protein, but also it's taken every other day, and there were some posters whether this every other day schedule would impact the patient reliability, and it looked like the patients did not complain, did not miss their doses. And whether the other question is, now it's becoming the standard of care using biomarkers to assess the short-term therapy changes. And Dr. Schiffman's group from Baylor, they look at whether this is a collaborative project with the Canadians too. So they looked at lysogb3, whether it was an accurate marker for therapy change or monitoring migalastat therapy. And they suggested lysogb3 may not reflect the therapeutic efficacy optimally in patients with who are switching or who are on migalastat treatment. Obviously, the data is not long-term, and we'll learn hopefully in the near future how the best monitor these patients with Fabry disease who are treated with oral chaperone therapy. So I'm going to be moving now from the FDA-approved treatments to the upcoming therapies, and they were more than few presentations on improved enzyme replacement therapy, either increasing the glycosylation sites or changing the glycosylation from mannose to another sugar, as we know that the mannose is used to be recognized and taken to the cell of this enzyme replacement molecule or the protein. The first presentation was from Spain, and this was the first poster. They suggested using some other modality rather than infusing, but using extracellular vesicles to take in the enzyme, and then these vesicles would be processed within the cell as any other vesicular compartment, and this will be and the enzyme will be presented to the lysosome, and the suggested effects or the benefits of this kind of system is to be able to deliver to multiple tissues, including the brain. The Hallows this was a collaborative project with Baylor and California group. They used different engineering techniques to produce different alpha-gal variants that improve their stability, efficacy, and also the immunogenicity. So any clinician that treats patients or infuses patients with Fabry disease, we know that actually that's the product is immunogenic, and we have related issues. We may have related issues to the immunogenicity of the protein. So there were multiple presentations on the new enzyme replacement modality that uses actually, this is a plant product that is produced in the tobacco plant, PEGI unigalsidase alpha. The difference between the other existing enzyme therapies for lysosomal disorders, the product is pegylated. So two molecules are attached together with polyethylene glycan residues, and this technique had been used to develop other therapeutic options such as interferon therapy, and has been used that has been used for some time now. Now this is being brought to lysosomal storage diseases. So theoretically, the PEG attachment would not only increase the half-life of the product, which there may be an issue because the half-life of the existing enzyme replacement therapies is very short in the circulation, so the tissue exposure actually is short too, theoretically. And so the results of phase 1 and 2 studies were presented by Dr. Hughes from United Kingdom. So they presented the data on the kidney biopsies and the Bliss scoring system to assess the GB3 positive cells, and the baseline Bliss score was 4.33 at the beginning, and which dropped to 0.83, which suggests the efficacy of the product. And also the switching study was presented by Dr. Alesh Linhart in poster 240, and also is an oral presentation. So this is an outside U.S. study, is mainly European. So that is the patients were switched from agalsidase alpha to PEGI unigalsidase alpha. So data from 16 of 22 adults with Fabry disease were presented. All patients were treated with agalsidase alpha, which is approved outside U.S. but not in U.S. The patients were treated at least for 2 years before they switched to PEGI unigalsidase alpha. So theoretically, they have been on stable therapy, and this presentation reiterated that was significant improvement after 1 year of PEGI unigalsidase alpha treatment. So from the enzyme replacement therapy, I'm going to move forward to another therapy modality, which is substrate reduction. So basically, substrate reduction therapy involves a small molecule. The difference between enzyme replacement therapy, actually you give the enzyme, which also reduces the substrate, but substrate reduction therapy goes to the pathway and to decrease the several glycosphingolipids that has a role in formation of globotriosine ceramide. The several authors took a place in phase 1 and 2 study on lucerastat as an oral monotherapy. We did not hear the results, but the study design of this phase 3 study. So actually World 2020 was the meeting for gene therapy, I'll put it. There were multiple posters and oral presentations, and the last day was almost dedicated mostly to gene therapy. So the data was presented by Dr. Hughes again, and they used an AAV S3 capsid. There is a phase 1-2 study is going on, and Dr. Hughes presented the first patient dosed with this modality of therapy. There is another company currently in the phase 1-2. There is the STAR study, and then I actually happened to present the poster in the meeting of this similarly liver-directed gene therapy using a different vector that is, but still will be directed to the liver, and liver will be the primary source of normal alpha-gal protein. There was not a result yet for this study. There are no patients dosed for it, but also this poster described the study design. So from the AAV or liver-directed gene therapy, I'm going to move to ex vivo gene therapy, or we can call it a stem cell therapy too. There were multiple presentations on other disorders using stem cell therapy. So the main difference between using AAV vectors and the stem cell therapy is you take the patient's cells and you isolate a group of cells, T cells, that are the CD34 positive cells, and you introduce the normal gene using another vector of a virus called lentivirus. The difference between the AAV viruses and the lentivirus is AAV does not get incorporated in our genome, as opposed to lentiviruses gets incorporated in the human genome. So the bone marrow will be producing cells, CD34 cells in this, the stem cells that will be the source for the normal protein. And they have conducted phase 1-2 studies in Canada and Australia. There is an effort there are 2 sites open for phase 1 studies in US, but there is no patient treated yet with this technique. So they have dosed 8 patients, and they presented data on few patients as case reports in this presentation by Dr. Walk et al. And in the study, this is a phase 1-2 study, the primary efficacy endpoint was a decrease in this GB3 GB3 positive inclusions. They presented the data from the first patient that is dosed in Australia. So there was 87% reduction of kidney biopsy at 48 weeks with stable clinical parameters for kidney and cardiac functions, and with a sustained alpha-gal activity in the white blood cells and the plasma. So this particular patient was able to discontinue the ongoing enzyme replacement therapy about 1.5 years after the dosing, and there were stable vector in the blood with stable alpha-gal levels. And among all these 8 patients, the adverse events mostly related with the myoablative conditioning. So this particular treatment requires suppression of the bone marrow using chemotherapeutic agents. So these agents may lead to decreased platelet count, decreased white blood cell count. So the AEs were related to this procedure, and also other pre-existing conditions, such as a patient who had seizures, actually had a seizure activity. So from all these studies, it is obviously a very exciting time. So in summary, World 2020 was not only very exciting meeting for us to learn what's going on in our European counterparts and also all around the world.